Hello everyone, today we will be starting the topic about drugs affecting the hematological system. Oral anticoagulation therapy has been used in primary care for more than 50 years, with a number of new oral anticoagulants introduced in the past 10 years. Oral anticoagulants such as warfarin, with the brand name being Coumadin, inhibit the hepatic synthesis of several clotting factors, including factor X. The decline in clotting factors is a function of the half-life of each factor, which varies from 5 hours for factor 7 to 72 hours for factor 2. Oral direct factor 10A inhibitors selectively inactivate circulating 10A and include rivaroxaban, with the brand name being Xarelto, apixaban, with the brand name being Eliquis, endoxaban, with the brand name being Savisa, and betroxaban, with the brand name being Bevixa. Heparin inhibits the activity of several activated clotting factors by accelerating the activity of antithrombin 3. LMWH, enoxaparin, with the brand name being Lovenox, potentiates the activity of antithrombin 3 and inactivates factors 10A and 2A thrombin. Fondaparinux, with the brand name being Arixtra, selective inhibitor of antithrombin 3 and factor 10A inhibitor. The coumarin derivative most commonly used is warfarin, with the brand name being Coumadin. Warfarin is rapidly and completely absorbed orally. Warfarin is metabolized by hepatic microsomal enzymes cyproheptadine 1A2 and 2C9 and is excreted primarily in the urine as inactive metabolites. Hepatic dysfunction potentiates the response to warfarin through impaired synthesis of coagulation factors. Hypermetabolic states produced by fever or hyperthyroidism also increase responsiveness to warfarin, probably by increasing the catabolism of vitamin K-dependent coagulation factors. Warfarin should be used cautiously with these patients. Increased risk for bleeding is also an issue with older adults. Cautious use based on a balance between the potential for decreased risk of thromboembolism and the risk of bleeding is necessary for older adults with dementia or severe cognitive impairment. History of 3 falls within the previous year or recurrent injurious falls, uncontrolled hypertension, or who are non-adherent or unreliable. Warfarin crosses the placenta and can cause hemorrhagic disorders in the fetus and serious birth defects. It is pregnancy category X and should not be administered during pregnancy. Warfarin has many drug interactions and increased INR monitoring. Within 4 to 7 days is recommended when other drugs are started or stopped, even short-term drugs such as antibiotics. Vitamin K has an antagonistic interaction with warfarin, decreasing warfarin's effectiveness. Warfarin interacts with any other drug that increases bleeding, including anticoagulants, antiplatelets, NSAIDs, and selective serotonin reuptake inhibitors, or SSRIs. Adverse reactions. Unusual bleeding is the most common adverse effect for all anticoagulants. Anticoagulant effect may be decreased by the following: oral contraceptives, carbazepine, and etc., or vitamin K containing foods. Clinical use and dosing. Drug of choice for deep vein thrombosis, or DVT, and pulmonary embolism, or PE. Start at 5 milligrams per day, 7.5 milligrams per day if weight is greater than 80 kilograms. Consider lower dose if older than 75 years, multiple comorbid conditions, elevated liver enzymes, and changing thyroid status. Dose to maintain international normalized ratio, or INR, between 2 and 3. Clinical use and dosing. Drug of choice for deep vein thrombosis, or DVT, and pulmonary embolism, or PE. Start at 5 milligrams per day, or 7.5 milligrams per day if weight is greater than 80 kilograms. Consider a lower dose if older than 75 years, multiple comorbid conditions, elevated liver enzymes, and changing thyroid status. Dose to maintain international normalized ratio, or INR, between 2 and 3. Monitoring. INR daily until in therapeutic range for 2 consecutive days. Then 2 or 3 times weekly for 1 to 2 weeks. Then less frequently, but at least every 6 weeks. Hello everyone. Today we will be continuing the topic about drugs affecting the hematological system. Heparin, including the LMWH drugs, dalteparin with the brand name being Fragmin, enoxaparin with the brand name being Lovenox, fondaparinux with the brand name being Arixtra, and tinzaparin with the brand name being Enohep, are not absorbed in the gastrointestinal tract and must be given IV or subcutaneously. Once absorbed, heparin is distributed in plasma and extensively protein-bound. Heparins are contraindicated in advanced hepatic or renal disease. They may be used in patients who are actively bleeding to treat disseminated intravascular coagulation, or DIC. Heparin is pregnancy category C. Heparins can also cause thrombocytopenia and anemia. The incidence of thrombocytopenia is up to 30% and is more likely with bovine than with porcine heparin. The antidote for enoxaparin overdose is protamine sulfate 1 mg for each milligram of enoxaparin. For dalteparin and tinzaparin, it is 1 mg for each 100 anti-10A international units of dalteparin. Cephalosporins and penicillins given parentally have both been associated with coagulopathies, increasing the risk of bleeding when given with heparin. Drugs that affect platelet functioning or cause hypoprothrombonemia, including aspirin, NSAIDs, dipyridamole, quinidine, and valproic acid, increase the risk of bleeding when used with any anticoagulant. Clinical use and dosing. Heparin, given 2 hours pre-operatively. Maintenance, every 8 to 12 hours for 7 days after surgery. LMWH, enoxaparin, DVT or PE, given 2 hours before surgery. Fondaparinux, DVT, hip fracture surgery or knee replacement. Dalteparin, prevention of DVT after abdominal surgery or hip replacement. Monitoring, activated partial thromboplastin time, platelet and hematocrit every 2 to 3 days initially. Anticoagulants should be taken exactly as prescribed at the same time each day, even if the patient is feeling well. Missed doses should be taken as soon as remembered the same day. Doses should not be doubled. For the heparins, which are injectable, the patient or family member must be taught correct subcutaneous injection technique. Oral anticoagulants may be taken without regard to timing of food intake. The type of food, however, is important. Ingestion of large quantities of foods high in vitamin K may antagonize the anticoagulant effect. Antiplatelet drugs. Aspirin, inhibits cyclooxygenase, interferes with platelet aggregation. Ticlopidine and clopidogrel reduces platelet aggregation by inhibiting adenosine diphosphate pathway. Vorapaxar, protease-activated receptor 1 antagonist, inhibits thrombin-induced and thrombin receptor agonist peptide-induced platelet aggregation. Taken with aspirin or clopidogrel, thrombin receptor agonist peptide-induced platelet aggregation. Antiplatelet drug pharmacokinetics. Aspirin, well absorbed when taken orally, metabolized in liver, renally excreted, pH affects excretion. Ticlopidine, rapidly absorbed after oral administration, metabolized in liver, half-life lengthens with repeated dosing, decreased renal clearance with age. Clopidogrel, prodrug, metabolized into active metabolite, excreted in urine and feces. Vorapaxar, metabolized by cytochrome 3A4 and cytochrome 2J2. Half-life is 8 days. Precautions and contraindications. Aspirin, hypersensitivity, cross-sensitivity with non-steroidal anti-inflammatory drugs, NSAIDs, pregnancy category C, D in 3rd trimester. Ray's syndrome in children. Clopidogrel and ticlopidine, avoid in patients with liver dysfunction. Vorapaxar, black box warning, not to use in patients with history of stroke or transient ischemic attack, or TIA. Adverse drug reactions of all. Bleeding. Aspirin may cause gastrointestinal bleeding. Salicylism or tinnitus. Ticlopidine, neutropenia. Dabigatran, dyspepsia, and gastritis-like symptoms. Antiplatelet drugs, interactions. Concurrent use of other antiplatelet, anticoagulant, or fibrinolytic drugs. Aspirin, herbals such as ginkgo, garlic, or ginseng. NSAIDs. Clopidogrel, proton pump inhibitors or PPIs, cytochrome 2C19 inhibitors. Ticlopidine, antacids, digoxin, cimetidine. Clinical use and dosing. Aspirin, myocardial infarction prevention, 75 to 162 milligrams daily. Persistent atrial fibrillation, 75 to 325 milligrams daily. Stroke or TIAs, 50 to 100 milligrams daily. Clopidogrel, myocardial infarction prevention, 75 milligrams daily. ST elevation acute coronary syndrome, 300 milligrams daily if younger than 75 years of age, and 75 milligrams daily if older than 75 years of age. Ticlopidine prevents stones in patients intolerant of acetyl salicylic acid, 250 milligrams twice daily. Vorapaxar, combined with aspirin or clopidogrel to prevent thrombotic cardiovascular events. Patient education for antiplatelet drugs. Administration. Take aspirin with a full glass of water. Aspirin must be stopped 7 days before surgery. Clopidogrel should not be taken with PPIs over-the-counter Prilosec or omeprazole, adverse drug reactions, aspirin toxicity, and bleeding. Hello everyone. Today we will be finishing up the topic about drugs affecting the hematological system. Hematopoietic growth factors are glycoprotein hormones that regulate the proliferation and differentiation of hematopoietic progenitor cells in bone marrow. Apoetin alpha, with the brand name being Epigen, EPO, or Procrit, and darbepoetin alpha, with the brand name being Aranesp, stimulate erythropoiesis, which is red blood cells, used for treatment of anemia caused by end-stage renal disease, AIDS, or chemotherapy. Preoperatively to prepare for allogenic transfusions. Granulocyte colony stimulating factor. Filgrastim, with the brand name being Neupogen, and pegfilgrastim, with the brand name being Neulasta, stimulates granulocyte formation, neutropenia caused by bone cancer and chemotherapy. Pharmacokinetics. All hematopoietic growth factors are well absorbed after subcutaneous injection. Some can be given through IV. The exact method of metabolism and excretion is unknown for most of these drugs, with some elimination thought to occur in the kidneys. Precautions and contraindications. The only contraindication for darbepoetin alpha and epiotin alpha is uncontrolled hypertension. Increases in erythrocyte production may also be accompanied by increases in extracellular fluid volume, which can increase blood pressure. The FDA requested the manufacturers of ESAs to develop a risk management plan regarding the increased risk of tumor growth and shortened survival in patients with cancer who receive these products. Darbepoetin and epiotin alpha are pregnancy category C. The only contraindication for filgrastim and pegfilgrastim is hypersensitivity to E. coli-derived proteins because this drug is derived from DNA manipulation of E. coli. Filgrastim and pegfilgrastim are pregnancy category C. Adverse drug reactions. All can produce bone pain. Epiotin alpha and darbepoetin include seizures, hypertension, and decreased overall survival rate and/or tumor growth in patients with certain cancers. Filgrastim and pegfilgrastim include hypersensitivity. Allergic-type reactions have developed with filgrastim on initial and subsequent treatment in fewer than 1 in 4,000 patients. Skin, respiratory, and cardiovascular system reactions common to most hypersensitivity reactions are typical. Drug interactions few. Clinical use and dosing. Epiotin alpha to treat anemia. 50 to 150 units per kilogram 3 times a week, depending on diagnosis. For allogenic transfusion, 300 units per kilogram per day given 10 days prior to surgery, day of surgery, and for 4 days after surgery. Darbepoetin 0.45 to 2.25 microgram per kilogram once weekly. Monitoring. Darbepoetin alpha, hemoglobin weekly. Epiotin alpha, hematocrit twice weekly, and blood pressure. Ferritin for both. Patient education. Administration. Self-administration of subcutaneous medication. Use of iron supplements. Adverse drug reactions. Hypertension and allergic reactions. Iron preparations. Iron is an essential mineral in the production of hemoglobin, myoglobin, and a number of enzymes. Pharmacokinetics. Absorption is enhanced in the presence of depleted iron stores and when erythropoiesis is decreased. Iron is primarily absorbed in the duodenum and upper jejunum by an active transport mechanism. The ferrous form is absorbed 3 times more readily than the ferric form. Factors that significantly affect absorption include sustained release forms, dose, and the presence of food. There is no mechanism for excretion of iron. Iron is lost mainly through shedding of the GI mucosal cells, with small losses in urine, sweat, and bile. Precautions and contraindications. The only contraindications to the use of iron are hemochromatosis and hemolytic anemia. Adverse drug reactions. GI symptoms are the most common adverse reactions and are usually mild. Irritation, anorexia, nausea and vomiting, constipation, or diarrhea may occur. Administering the iron with food reduces most of these problems. Acute iron toxicity is seen almost exclusively in children who have ingested many iron tablets. As few as 10 tablets of common oral iron preparations can be lethal in young children. Drug interactions involve chelation, such as levodopa, penicillamine, and quinolones, or competition for absorption, such as antacids, cimetidine, methyl-dopa, and tetracyclines. Clinical use and dosing. Iron deficiency anemia. Treatment for 3 to 4 months after hemoglobin hematocrit return to normal. Adults 150 to 300 mg elemental iron daily. Premature infants 2 to 4 mg per kilogram per day. Infants and young children 4 to 6 mg per kilogram per day. Monitoring. Reticulocyte count 7 to 10 days after starting therapy. Hemoglobin at 2 weeks, then based on individual risk. Patient education. Prevention. Prevention of iron deficiency is the most important issue. The average American diet contains about 12 milligrams of iron daily. 20% of this is absorbed in markedly deficient patients, but only 10% is absorbed in normal patients. Eating iron-rich foods can prevent the need for iron supplements, especially in adults. Red meat is the best source of iron, but fish and iron-enriched breads and cereals are also good sources. Administration. Patients should take iron as directed. Iron should be taken on an empty stomach. If GI upset occurs, iron can be taken with food, but the amount absorbed will be less. Taking it with vitamin C or citrus juice may enhance absorption. Patients should avoid taking iron at the same time as milk, antacids, tetracycline, or quinolones, which decrease absorption. Adverse responses. Constipation is the most common problem in patients taking iron. Increase fluids and fiber in the diet, especially iron-rich cereals. Stools may turn dark green or black. This color change is harmless. A stool softener may be used if needed to treat constipation. Acute iron toxicity/poisoning can occur with an overdose. This is especially a problem with children, in whom as few as 10 of the commonly available iron tablets can be fatal. Patients should keep iron preparations in child-proof containers and in a locked medicine cabinet, and not refer to vitamins or drugs as candy. Folic acid. Folic acid deficiency is most often related to inadequate dietary intake of green vegetables or excessive boiling of these vegetables in cooking. Other sources of folic acid deficiency include impaired absorption because of ileal disease or phenytoin use, increased demand during pregnancy, hyperthyroidism, hemolytic anemia, or malignancy, and impaired utilization for patients taking methotrexate, triamterene, and trimethoprim. Pharmacokinetics. Oral folic acid supplements are well absorbed from the proximal jejunum, and intramuscularly or subcutaneous administration also results in excellent absorption. Folic acid is converted by the liver to its active metabolite, dihydrofolate reductase. Folates are excreted in the urine and stool and destroyed by catabolism so that serum levels fall within days when intake is inadequate. Folic acid clinical use. Anemia caused by folic acid deficiency. Initial dose 1 mg per day in adults and children. Maintenance dose. Infants 0.1 mg per day. Pregnant or lactating women 0.8 mg per day. Prevention of folic acid deficiency 0.4 mg per day prior to conception and during pregnancy. Vitamin B12. Vitamin B12 deficiency can be caused by poor intake, impaired absorption, increased demand, or faulty utilization. Poor intake is rare except in strict vegetarians who do not eat eggs or use dairy products. Impaired absorption is most often related to the lack of intrinsic factors found in pernicious anemia. Absorption can also be impaired by diseases of the ileum, by bacterial overgrowth from stasis, such as occurs with severe constipation, and by altered digestive enzymes associated with gastrectomy. Faulty utilization is associated with rare genetic defects. Pharmacokinetics. Vitamin B12 is well absorbed after intramuscular and subcutaneous injections or intranasal administration. Excess vitamin B12 is stored mainly in the liver and released when needed to carry out normal cellular functions. After injection, vitamin B12 is stored in the liver for approximately 400 days. Within 48 hours after injection, 50% to 98% of the dose appears in the urine. The major portion is excreted within the first 8 hours. Vitamin B12 clinical use. Prevention of deficiency. Pregnancy 2.2 micrograms per day. Lactation 2.6 micrograms per day. Infants 0.3 to 0.5 micrograms per day. Children age 1 to 10 years old 0.7 to 1.4 micrograms per day. Treatment of deficiency 1,000 micrograms oral cobalamin daily for 6 to 12 weeks. Pernicious anemia. Initial dose 1,000 micrograms per day intramuscularly or subcutaneously for 7 days, then 100 to 1,000 micrograms intramuscularly per week for a month. Maintenance 1,000 micrograms intramuscularly monthly, 500 micrograms intranasal, cyanobalamin weekly, 1,000 micrograms orally daily. Hello everyone. Today we will be starting the topic about drugs used to treat inflammatory processes. Corticosteroids. Cortisol, the endogenous glucocorticoid in the body, is produced and secreted on the basis of feedback mechanisms of the hypothalamus-pituitary-adrenal axis. Corticosteroids have a major role in the management of a variety of disease processes. In primary or secondary adrenal cortex insufficiency, they are used for replacement therapy. In rheumatic disorders, they may be short-term adjunctive therapy for acute episodes or exacerbation. These drugs are also used to treat collagen disease, dermatological conditions, asthma, allergic rhinitis, neoplastic disorders, inflammatory bowel disease, and idiopathic thrombocytopenia purpura. Glucocorticosteroid actions. Inhibits immune and inflammatory systems. depresses proliferation of T lymphocytes, decreases natural killer cell activity, and reverses macrophage activity, increases circulating erythrocytes, increases appetite, promotes fat deposits in the face and cervical areas, promotes lipolysis in the extremities, increases uric acid excretion, decreases serum calcium levels, promotes gastric acid secretion, suppresses secretion and synthesis of adrenocorticotropic hormone, suppresses prostaglandin E production of growth hormone secretion, causes skeletal wasting, potentiates the effects of catecholamines, thyroid hormone, and growth hormone on adipose tissue. Mineralocorticoids, predominantly aldosterone, is to retain sodium in water and excrete potassium. Corticosteroids pharmacokinetics, well absorbed from the GI tract, metabolized by the liver. Metabolites are active. Cortisone is converted to hydrocortisone. Prednisone is converted to prednisolone, excreted by the kidneys. Corticosteroids, precautions, contraindicated in patients with active untreated infections, cautious use in patients with hypertension and cardiovascular disorders, may elevate blood pressure, salt and water retention, and increase excretion of potassium. Cautious use in postmenopausal women and others at risk for osteoporosis. Patients with diabetes may have problems with glycemic control. Patients with ulcerative colitis or peptic ulcer disease may have increased risk of gastrointestinal bleed and perforation. Adverse drug reactions, muscle and skin. Common skin changes reported with systemic corticosteroids include atrophy and thinning of the skin, alopecia, acneiform eruptions, poor healing, purpura, striae, hirsutism, and desquamation. Myopathy is also seen with marked muscle wasting. No relationship between dose or duration of therapy and these adverse reactions is apparent. Alteration in body fat is also noted, particularly in patients who take corticosteroids for more than 60 days, with the most common changes being truncal obesity, buffalo hump, and moon face. Skeletal tissues. Osteoporosis develops in 11% to 20% of patients treated with glucocorticosteroids for more than 1 year, with decreased BMD found within the first 3 months of therapy. Skeletal fractures, mainly of the spine, ribs, and pelvis, may occur secondary to the reduced bone density, with 10% of patients on long-term therapy diagnosed with a fracture. Ocular tissues. Prolonged use of corticosteroids may produce subcapsular cataracts, glaucoma with possible damage to the optic nerve, and increased risk for secondary ocular infections due to fungi or viruses. Gastrointestinal system. Corticosteroids have been implicated in the induction of peptic ulcer disease. Patients who appear to be at risk are those being treated for nephrotic syndrome or hepatic disease, taking a total dose of prednisone exceeding 1 gram, or having a history of ulcer disease, concomitant use of known gastric irritant or stress. Cardiovascular system. Hypertension is a common adverse reaction and fluid and electrolyte disturbances. Central nervous system. Delirium, agitation, insomnia, mood swings, and severe depression categorize steroid psychosis. The onset of symptoms is usually within 15 to 30 days. Predisposing factors include doses above 40 milligrams of prednisone or its equivalent dose in another drug, female gender, and a family history of psychiatric disorder. Endocrine system. Prolonged therapy with corticosteroids may lead to adrenal suppression. Abrupt withdrawal after adrenal suppression has occurred may result in a withdrawal syndrome, with symptoms similar to those seen in adrenal insufficiency. Corticosteroids, clinical use and dosing. Adrenal insufficiency. Drugs of choice are hydrocortisone, cortisone, and prednisone. Hydrocortisone, 50 milligrams every 8 hours for 48 hours for adults, then tapered to 20 milligrams per day. Cortisone, 25 to 300 milligrams per day, divided twice daily, tapered over 14 days to 15 to 20 milligrams per day. Prednisone, 5 to 60 milligrams per day, divided twice daily, tapered to maintenance of 5 to 20 milligrams per day. Give morning dose before 9 a.m. Inflammation. Methylprednisolone, prednisone, and triamcinolone or dexamethasone can be used. Immune suppression. Prednisone is used because of its short half-life. Different strength tablets make dosing and tapering easier. Rheumatoid arthritis. First-line therapy is NSAIDs. Low-dose prednisone, less than 7.5 milligrams per day, can be used. Prophylaxis with a bisphosphonate and calcium/vitamin D will lower risk of osteoporosis. Corticosteroids. Principles of prescribing. 1. To best match the natural body rhythm. Daily doses are best taken in the morning before 9 a.m. 2. The initial dose depends on the specific disease being treated. Maintain or adjust the dose until an acceptable response is achieved. 3. After an acceptable response is achieved, determine the maintenance dose by tapering until the lowest dosage that maintains an adequate clinical response is reached. 4. If after long-term therapy or because of spontaneous remission, the drug is to be stopped, taper off to prevent an adrenal insufficiency crisis. Tapering is generally not necessary after short-term therapy. 5. Most conditions that require chronic corticosteroid therapy can be well controlled on alternate day therapy. Twice the daily dose is given every other morning before 9 a.m. 6. Unlike a tapering schedule, alternate day scheduling retains the same total steroid dose. Rational drug selection. Length of therapeutic activity. Corticosteroids are classified according to their therapeutic effects into short, intermediate, and long-acting forms. Short-acting agents are less likely to produce HPA suppression, especially when taken only in the morning and in low doses on an alternate day schedule. Long-acting agents are preferred if the effects of high doses must be sustained. For example, increased intracranial pressure or organ transplant rejection. Relative potency. Mineralocorticoid activity is desirable in adrenocortical insufficiency, but not if the primary goal of therapy is anti-inflammatory or immunosuppressive. Drugs with higher relative mineralocorticoid potency, or RMP, are selected for adrenal insufficiency. Drugs high in relative anti-inflammatory potency, or RAP, are selected when the goal is to reduce inflammation or suppress the immune system. Monitoring. Monitoring is based on the common adverse reactions associated with the use of corticosteroids. Weight gain, edema, hypertension, and indications of excessive potassium loss and negative nitrogen balance associated with protein catabolism. Laboratory monitoring begins with an initial assessment of serum electrolytes, glucose, and complete blood count. For patients on long-term therapy or high doses, annual monitoring of these parameters as well as guaiac testing of stools and serum lipid analysis is appropriate. For patients at risk for or with indications of GI adverse reactions, upper GI x-rays are desirable. Systemic corticosteroids may produce subcapsular cataracts in as many as 30% of patients, and patients who have or are at risk for increased intraocular pressure may experience increases in intraocular pressure while on these drugs. A slit lamp examination is recommended every 6 to 12 months for patients on long-term corticosteroid therapy. Corticosteroids, patient education. Administration. Instruct patient to take exactly as prescribed. Explain alternate day or tapered dosing. Drugs should not be abruptly discontinued. Adverse drug reactions. Immune suppression, GI bleeding, and non-healing sores. Changes in body habits, mood changes. Advise patients to wear medical identification that describes their disease process and drug regimen in the event of a medical emergency that prevents patients from relating their medical history. They should also inform any healthcare professional who provides care that they are taking corticosteroids. Lifestyle management. A diet high in protein, potassium, and calcium, and low in sodium and carbohydrates can counteract some of the adverse reactions associated with corticosteroids. Multivitamins with minerals, calcium, and vitamin D are appropriate. Caloric management to prevent obesity should also be implemented. Alcohol should be avoided during therapy. Osteoporosis risk can be reduced not only with calcium intake, but also with regular exercise. Because stress can be a source of HPA stimulation, stress management techniques are used. Hello everyone, today we'll be continuing the topic about drugs used to treat inflammatory processes. NSAIDs inhibit cyclooxygenase activity, thus inhibiting prostaglandin synthesis. COX-1 is present in all tissues and cells, especially platelets, endothelial cells, the GI tract, and renal microvasculature, glomeruli, and collecting ducts. COX-2 is an inducible enzyme that is synthesized mainly in response to pain and inflammation. NSAIDs are primarily used for pain and their anti-inflammatory activity, also effective antipyretic. Acetaminophen is an analgesic and antipyretic with limited anti-inflammatory activity. Although its mechanism of action is not known, it is thought to act by inhibiting central and peripheral prostaglandin synthesis. The central inhibition is almost as potent as that of aspirin, but its peripheral action is minimal. It reduces fever by direct actions on the hypothalamic heat-regulating centers, which increases dissipation of body heat via vasodilation and sweating. It has the advantages of minimal GI irritation and of not affecting bleeding times, uric acid levels, or respiration. Absorption and distribution. After oral administration, NSAIDs are rapidly and almost completely absorbed. In general, food delays absorption of all NSAIDs, but does not affect the total amount absorbed. Administration with food reduces GI adverse reactions. Metabolism. The NSAIDs are all metabolized by the liver and excreted by the kidneys primarily as metabolites. Acetaminophen is extensively metabolized by the liver and excreted by the kidneys, primarily as inactive metabolites. When it is taken regularly or in large doses, the stores of one hepatic conjugate becomes depleted and hepatic necrosis may occur. Adverse drug reactions. The most common adverse reactions with NSAIDs are GI disturbances, in particular nausea, vomiting, constipation, and diarrhea. Taking the drug with food can reduce these reactions. Acute renal insufficiency has occurred in patients with pre-existing renal disease or compromised renal perfusion. NSAIDs inhibit platelet aggregation and may increase bleeding time. Fluid retention and peripheral edema are not severe but can be problematic for patients with compromised cardiovascular function. COX-2 inhibitors and all NSAIDs have black box warning for patients about cardiovascular risk. All NSAIDs may increase the risk of a heart attack or stroke. Acetaminophen poisoning. Acetaminophen is a common cause of poisoning, either intentional or accidental, because the lay public underestimates the toxicity of the drug. A single dose of 150 milligrams per kilogram of acetaminophen in children, or 7.5 grams to 10 grams in adults, may be toxic. Acute acetaminophen poisoning should be referred to a hospital with a poison control center. If this is not possible, the following treatment regimen may be followed. If the acute ingestion is more than 150 milligrams per kilogram, or the dose cannot be determined, obtain a serum acetaminophen assay 4 hours after ingestion. If the level is more than 300 milligrams per milliliter, hepatic damage will have occurred in 90% of patients. Oral N-acetylcysteine is a specific antidote for acetaminophen toxicity. Contact a poison control center for correct dosing of the antidote. NSAIDs, clinical use and dosing. Rheumatoid arthritis. Use NSAIDs or celecoxibs to reduce joint pain and swelling. Follow American College of Rheumatology suggestions for treatment. There is increased risk for complications, so monitor closely. Osteoarthritis. Acetaminophen or NSAIDs can be used for pain. Gout. Indomethacin, naproxen, and Cilindac. Mild to moderate pain. Non-opioid analgesia includes NSAIDs and acetaminophen. Ibuprofen and naproxen are most commonly used. Primary dysmenorrhea. NSAIDs such as ibuprofen or naproxen are the drugs of choice. Tendinitis and bursitis. Indomethacin SR, naproxen, and Cilindac are used. Fever. Ibuprofen is the drug of choice. Acetaminophen, clinical use. Drug of choice for mild to moderate pain in pregnancy, patients with history of GI bleed, aspirin allergy, blood coagulation disorders, and upper GI disease. Drug of choice for fever in above adults, children, infants younger than 6 months of age, and especially children with fever during flu-like illnesses. NSAIDs monitoring. NSAIDs, renal function with long-term therapy, GI ulcer or GI bleed, CBC prior to initiation of therapy and annually thereafter. Acetaminophen, dosing for overdosing with self-medication, liver function if on high dose or long-term therapy. NSAIDs, patient education. Administration, take as directed. Limit alcohol consumption. Maximum acetaminophen dose is 3 grams per 24 hours. Adverse drug reactions. Report GI upset or coffee ground emesis. Hello everyone. We will be finishing up the topic about drugs used to treat inflammatory processes. Aspirin and salicylates. These drugs have analgesic, anti-inflammatory, antipyretic, and antiplatelet activities. The anti-inflammatory and analgesic activities are mediated through inhibition of prostaglandin synthesis. Aspirin irreversibly inhibits platelet aggregation. Aspirin pharmacokinetics. Rapidly and completely absorbed after oral administration. Food slows absorption. Widely distributed to all tissues. Metabolized by liver and eliminated via urine. Urine pH influences excretion. Adverse drug reactions. The most common adverse reaction to salicylates is GI irritation and bleeding. Although fecal blood loss is lower with enteric-coated products, these drugs have erratic absorption and still must be used cautiously by patients with GI disorders. Ototoxic at higher levels. Aspirin used by children or adolescents with influenza or chickenpox associated with the development of Ray's syndrome. Avoid after surgery because of bleeding risk. Pregnancy Category D. Toxicity. The acute lethal dose of salicylates in adults is 10 to 30 grams, and in children it is 3 grams. Signs of salicylate poisoning appear at serum levels of 30 to 60 milligrams per deciliter. Respiratory alkalosis is seen initially. Hyperpnea and tachypnea occur as a result of increased carbon dioxide production and a direct stimulatory effect of the salicylate on the respiratory center in the brain. Treatment for salicylate toxicity includes induction of emesis or gastric lavage to remove any unabsorbed drug from the stomach. Activated charcoal diminishes salicylate absorption if it is given within 2 hours of ingestion. Hemodialysis is reserved for those patients with severe poisoning. Aspirin, clinical use and dosing. Fever. Aspirin is effective antipyretic. Do not use in pregnant patients or children. Mild to moderate pain. Aspirin is gold standard for pain management. Rheumatoid arthritis. Aspirin is the gold standard. Margin is narrow between a good therapeutic level and toxicity in treating patients with rheumatoid arthritis. Juvenile patients with rheumatoid arthritis take aspirin. Osteoarthritis. Aspirin works well to treat pain. Acute rheumatic fever. Inflammatory manifestations are treated with aspirin. Aspirin, myocardial infarction prophylaxis. Daily treatment of 81 to 325 milligrams of aspirin in patients with myocardial infarction has been associated with a 20% reduction in risk of subsequent and non-fatal reinfarction. At first sign of a myocardial infarction, patients should take one 325 milligram aspirin tablet. Transient ischemic attacks. Aspirin 50 to 325 milligrams per day for stroke prevention. Monitoring. A random salicylate level should be determined 7 to 10 days after initiation of chronic therapy. Because of all these drugs are eliminated by the kidneys and dosage adjustments may be required based on renal function, serum creatinine levels should be assessed before therapy is begun and annually throughout long-term therapy. A CBC and fecal occult blood studies should also be done if there is any indication of GI bleeding. Administration. Instruct the patient to take salicylates exactly as prescribed. Taking with food or a full glass of water and remaining in an upright position for 15 to 30 minutes after administration can reduce GI irritation. Food slows absorption but does not alter the total amount absorbed. Remind patients not to crush or chew enteric-coated tablets or take antacids within 1 hour of enteric-coated tablets. Chewable tablets may be chewed, dissolved in liquid, or swallowed whole. Tablets with a vinegar-like odor, acetic acid, should be discarded. Adverse reactions. The most common adverse reactions are ototoxicity and GI irritation and bleeding. Ray's syndrome practically disappeared after the Centers for Disease Control and Prevention started warning that aspirin should not be given to children or adolescents with influenza-like syndromes, or chickenpox because of a possible association with Ray's syndrome. Parents should be informed of the risk of Ray's syndrome and warned not to give aspirin to a child with a viral illness. Lifestyle management. Rest, heat, exercise, and other lifestyle modifications are part of the management of arthritic conditions. The modifications are as important as the pharmacological management and should be stressed.